Hello everyone. I hope and I believe you all are doing great. This is Dr. Arya, your pathology faculty. Today we will be studying the topic of thrombotic microangiopathies. Okay, so thrombotic microangiopathies are basically characterized by a microangiopathic hemolytic anemia. Okay, I know we have not even started the topic of hematology, but I know you have a basic knowledge of hemat, right? That you have read in your physiology. Then there will be thrombocytopenia, and after everything, what will happen? The person will be gone. There will be end organ damage, not gone, okay? There will be end organ damage. So what are the types that you have? Mainly the types that you have are primary, then you have the secondary, then you have the systemic. In the primary one, what you need to remember? In the primary one that you need to remember, you have something called as the TTP that is associated with Shiga-like toxin. I hope you have read your microbiology very well. Okay. In your secondary, it is related to your quinine and mitomycin C. Mitomycin C is basically for your ENT uses. It is mainly used in your ENT posters. Okay. In the systemic one, it is associated with the SLE. If we are talking about the system, then we have to mention SLE. Otherwise, it will what? It will be sad. SLE will be sad, right? Then you have the malignant hypertension and pregnancy. Okay. What is the pathogenesis? So for the pathogenesis of TTP, there will be this mutation, there will be deficiency of this particular thing, as a result of which it will lead to ultra large VWF. After that, there will be the platelet aggregation. After the platelet aggregation, you know what will happen? There will be thrombocytopenia. HUS, you have the atypical one and you have the typical one. In the typical one, you have the Shiga-like toxins that will cause the endothelial injury. In the atypical one, there will be the complement dysregulation. And in the drug-induced one, there will be direct endothelial toxicity or immune-mediated. Let's see the pathophysiology. There is complement-mediated hemolytic uremic syndrome. What is the pathophysiology? There will be a genetic deficiency first, as a result of which what will happen? There will be a gain of function in the complement system and they require the autoantibody, as a result of which there will be dysregulation, activation of the alternate pathway. Firstly, there was complement pathway. Now there will be activation of the alternative pathway. Now there will be a loop of the alternative pathway that will go on, that you will read in your microbiology for sure. Now what happens is this alternative pathway will get converted into the C5 convertase and there will be the formation of thrombus. The ultimate thing which you need to remember is there is a formation of what? There is a formation of thrombus. In the pathophysiology, in the gross, the kidneys are cortical and pallor and you are able to see the petechial hemorrhages. In the microscopy one, see, you are able to appreciate what? The fibrin platelet and thrombi in arterioles and capillaries. Okay, these are the things that you are able to appreciate. What are the clinical features? So in the clinical features, in the TTP, you have a pentad of, there will be anemia, there will be thrombocytopenia, renal involvement and neurological symptoms. In the hemolytic one, you have a triad of anemia, thrombocytopenia, acute kidney injury that will cause the oliguria, hematuria and proteinuria. And in the drug-induced one, you have the anemia, you have thrombocytopenia and organ damage. What are the investigations we will order? Investigation that we will order. First one will be your CBC, like you will be able to appreciate anemia and thrombocytopenia. In your peripheral smear, you will be able to appreciate the cystocytes and the Hemolytic cells. In the LDH is elevated, then you will do the Coombs test. When you will do it, will come out to be negative. In the renal function, there will be increased level of creatinine. Then you will order the stool culture to detect if any toxins are there or not. What is the treatment? So for the treatment of TTP, you will give the plasma exchange and corticosteroids. For HUS, you will give a supportive care and dialysis if needed. For atypical one, you will give the 𝗲𝗵𝗵𝗵 and dialysis if required. For drug induced, you have to stop the drug and give the supportive care to the patient. Let's see the prognosis and the key points for the TTP. Untreated mortality leads to 90% of the death, and there is plasma exchange survival is more than 80%. In the typical HUS, remember it usually recovers. Atypical HUS, it has higher risk of chronic kidney disease. Secondary TMA depends on the cause and intervention of the timing. Memory triggers are present in TMA. In TTP, remember it is found in adults and it has a pentad. In HUS, remember it is found in the children. This is the main important and distinguishing point which you need to remember. In the peripheral smear, you are able to see the schistocytes and the Hemolytic cells, and the treatment we give the plasma exchange and the supportive treatment like 𝗲𝗵𝗵𝗵𝗵. So this was a really short topic. I hope I made myself very clear. If you're having any sort of doubt, you please feel free to ask me. Please feel free to reach out to me and DM me. Thank you so much.